My disclosure is that I am a consultant for Interscope. So they are the sponsor of our webinar this afternoon. I'm also the inventor of the AXIOS lumen-apposing metal stent and delivery system. Now, the two are really interlinked because AXIOS, I developed it as a port to enable us to access the extraintestinal space more safely and more reliably and predictably with outcomes that we can justify dissemination with. Yes, a few exotic centers have been doing this for many years now. We've been draining the gallbladder, doing gastroenterostomies, draining the bile duct under EOS guidance. All of this is not totally novel, but with AXIOS, we have a tool that allows us as a lumen-apposing stent to really have apposition of the two cavities. And this is a very critical part of our treatment of WAN. So the endorotor that you will be hearing a lot about this afternoon, it is the first tool that we can introduce through an AXIOS, a lumen-apposing metal stent, to target this specific therapy of necrosectomy. So let's talk about walled-off necroses first. It is defined as an encapsulated collection of pancreatic and/or peripancreatic necrosis with mixed liquid and solid contents. So that mixture of liquid and solid is the key signature of a WAN. And there are many prior descriptors for the same thing. For a long time, we called them organized necrosis. It was also called a post-necrotic fluid collection, post-necrosis pseudocyst, a pseudocyst associated with necroses. So it's no wonder that that term pseudocyst and WAN have been used really interchangeably. In fact, pseudocyst was just the term we used for anything that looked like it was fluid filled as a consequence of acute pancreatitis. So if we have a patient with acute pancreatitis, 85% of these cases will resolve really quite without significant sequelae. Patients will develop interstitial pancreatitis. This may then form into an acute fluid collection, an AFC, and then if it persists for more than 4 weeks and develops a mature wall, then we have a pseudocyst, and this is only filled with fluid. On the other hand, in 15% of patients, necrotizing pancreatitis may develop. And this in turn may develop into an acute necrotic collection, an ANC. And if that persists for more than 4 weeks and develops a mature wall, then we have a WAN. And a WAN, its signature, as mentioned, fluid and necrosis. To make that differentiation of a pseudocyst, which is purely fluid, from a WAN, mixed liquid and solid, you need to obtain an MRI. A CT scan is simply not sufficient. There is a study that documented the value of a T2 weighted MRI compared to a CT scan in evaluation for solid debris. And this found that the MRI had 100% sensitivity versus only 25% in patients undergoing contrast-enhanced CT scans. But there are also many other advantages to obtaining an MRI over a CT scan because we can evaluate the ducts at the same time. We can evaluate for pancreatic duct disruption or obstruction. In the CBD, we may see a stone that may be the cause of the patient's pancreatitis. We can evaluate vessels, in particular, evaluate for a pseudoaneurysm. That's so important that we evaluate for a pseudoaneurysm. At a minimum, we should be looking at our CT scans very closely and then on EUS for a pseudoaneurysm. And there's no radiation and there's no contrast nephrotoxicity. So these are all advantages to getting an MRI. So why aren't we getting MRIs on all our patients? I think it's mainly a cost issue, but it's also an issue that the exam takes longer, and some of these patients are a lot sicker, and so they may not tolerate the time needed to get an MRI scan. So that's, I think, the real limitation. Otherwise, we really should be getting MRIs on all of our patients. The recommendation of the ESGE last year was an MRI with secretin enhanced quality, so an SMRCP, something that we don't really routinely do in the US or is not as widespread, is recommended for characterizing pancreatic fluid collections and the MPD anatomy before endoscopic drainage of pseudocysts. So it is a weak recommendation, low quality of evidence, but it is in the guidelines. 1996. It was a great year for Todd Barron and a great year for us. You know, Todd is the first to describe endoscopic therapy for what we then called organized pancreatic necroses. So we didn't use the term WAN yet. And in this study of 11 patients, all patients with more than 50% necroses on CT scan, he placed a 10 French stent and a nasocystic catheter for irrigation until full resolution. And resolution occurred in 9 of the 11 patients. However, the mean duration of nasocystic catheter lavage was 19 days. So that's over 2 weeks just undergoing NCC irrigation. The mean hospitalization was 15 days. I'm not quite sure why the hospitalization was shorter than the nasocystic catheter lavage, because you'd think that these patients are all inpatient when undergoing the lavage, but maybe some were discharged earlier. Complications occurred in 56%. So this was not a benign procedure by any means. 1 massive bleed, 1 perforation. But this was the first time that organized necroses, which otherwise was completely in the domain of the surgeon, was embraced by the endoscopist. And then in 2000, a Dr. Seifert, who used to work with us in Hamburg with Nibs Sahendra, where he and us in Hamburg began performing this procedure, direct endoscopic necrosectomy. So now we're talking about going directly with our endoscope into the walled off necroses and doing necrosectomy. So this was proof of concept 3 cases, all had failed prior stent drainage. You have to very aggressively dilate to create the tract to enter into the WAN. Necrosectomy was performed with the usual off-the-shelf tools, and the patients underwent weekly necrosectomies until resolution. Now, this term debridement, don't get the term debridement mixed up with necrosectomy. Debridement can be indirect, which is accomplished with irrigation. So irrigation itself is very effective at debridement, but obviously it doesn't require any direct interface with the tissue. Direct is necrosectomy. We also call this DEN, D-E-N. So we can perform this endoscopically with the nasocystic catheter, as Todd did. We can also do this percutaneously. This is what our radiology colleagues do. And these can not only be irrigated, but also it can be actively lavaged because you have direct access from outside. And then for direct necrosectomy, we have, as you can see here, a direct entry with our endoscope, but the surgeons now are also performing direct necrosectomy, either laparoscopic or with the VARD procedure. This is an important study because this pretty much brought the whole debate, surgery, even if it's minimally invasive, surgery versus endoscopic drainage, which should be the procedure of choice or the intervention of first choice. And this study here, even though it's small, but it very conclusively showed that endoscopic transgastric necrosectomy performed in all 10 patients was superior to surgical necrosectomy, of which most of these patients had the VARD procedure, though some required an open procedure if they could not accomplish necrosectomy with the VARD procedure. But the major complication rate was significantly lower in the endoscopy group. And they also looked at IL-6 levels, and they found that the inflammatory markers were significantly reduced in the endoscopy group. So this hopefully put that debate to rest. But if there's any doubt about surgery versus endoscopy, you can also quote this study from the Florida group from last year. And they did a randomized trial comparing a minimally invasive surgical approach. So that was laparoscopic or VARD compared with endoscopic drainage. Now, not endoscopic necrosectomy necessarily, because not all patients underwent necrosectomy. It was only done in 44%, the direct necrosectomy. But they all had, of course, stent drainage. And here, the major complication rate was found to be significantly lower in the endoscopy group. The quality of life indices were significantly better in the endoscopy group, and the cost was significantly lower in the endoscopy group. There were many endoscopic confounders that I want to point out. 35% of the endoscopy patients had prior percutaneous drainage. Plastic versus LAMS, about half and half. So we're not necessarily comparing apples to apples. The multi-gate procedure was performed in 2/3, and that's something the Florida group likes to do, the multi-gate versus single gate. And this was done with both plastic stents and LAMS. And then, as mentioned, necrosectomy, direct debridement, was performed in only 44%. So not everyone got necrosectomy. But when you go inside of a wand, you realize these wands are not created equal. They come in all colors, in all shapes, in all consistencies. It's really remarkable how varied the necroses can appear. And sometimes they're quite loose and it's easy to remove them. But other times it's like chewing gum stuck to the sole of your shoe, and it's just really hard to remove these. So the first challenge we have faced when performing necrosectomy is that we have to create a large opening to get our scope through, to pass it through into the wand. This generally requires a 15 to 18 millimeter balloon, sometimes even 20. And obviously this carries risks of perforation, leak, and bleeding. So here's a big balloon, and we're all holding our breath every time we did this. And you see this, this large CRE balloon in place. And then here is what I called fenestration, because it's like a window that you can now climb through to get into the wand. The second challenge was removing these necroses. We had no dedicated tools for this. We grabbed tools we had on our shelf, and these were always, as a rule, difficult to remove with these off-the-shelf tools, with risks of bleeding, perforation, and air embolism. So I actually always worked underwater. That should be no surprise, but to reduce that risk of air embolism. And nearly always multiple sessions were needed. So here you see some of these off-the-shelf tools. This is a Dormia basket. This is a net. This is a rat tooth forceps, a snare, and even a cap. And it's really no surprise, given these two significant challenges, that our major complication rate was 36% if we compiled several studies here with more than 10 patients enrolled, such that it was Dick Kazarek who wrote an editorial. I love this editorial. Read it, please, if you want to read a really good editorial that sums up the challenges that we face treating wands, called Endoscopic titled Endoscopic Management of Pancreatic Necrosis, Not for the Uncommitted. or as Dick also used to say, not for the faint-hearted. These were always very difficult procedures. And this is why I'm very proud that we could develop the LAMS as a port to now more easily and safely enter into the wand to perform necrosectomy. So the LAMS is a port for direct endoscopic necrosectomy. You know, you may have adherence of the wand to the gastric wall, for example. So you don't need it in the same manner that you'd want a wand for gallbladder drainage, which is not adherent. The lumen-apposition here is the stability of the stent so that you can go in and out of the cavity without dislodging the stent each time. So we've had SEMS for some time, but you couldn't do necrosectomy through a conventional tubular SEMS. This video shows one example of how we're using the LAMS as our port. And here you can see the inside. And I always like to irrigate first with dilute hydrogen peroxide, and I'll do that with a few liters until it's clean. And I'll bring the patient back a week later. So I'll let the tract mature. You could do it in the index session, but there is a small risk that you might dislodge the lamb. So you really would prefer to have the tract mature, and then you can be more aggressive. And I bring these patients back weekly. I don't spend more than 15, max 20 minutes doing this. It's not like the old days where we'd wipe out the whole afternoon doing necrosectomy. So it's really just going in and pulling out the loose necroses, the necroses that you can easily capture and pull them out. But you did have to bring the patients back weekly. And as you can see here, this patient required 3 or 4 sessions to finally get to clear the necrosis. And then we can remove the LAMS. And here you can see before and after. Just because this is the way I do it. So I love to put a cap on the end of my scope, and then I just suck in the loose necroses into the cap. And then I use the biopsy forceps, but you'll notice I do nothing blind. I am really not in favor of using snares and baskets, anything pointed, because when you actually look at the wall, the pseudo wall of a wand, you see all these vessels. I actually drove my echo endoscope inside the wand once and looked around. It's like it lights up like a Christmas tree with vessels. And of course, you've got really mean players like the splenic artery there and the hepatic artery, et cetera. So you need to be really careful when you're doing necrosectomy. It should never be blind. So I just removed the loose necroses, and this is my last slide, which will be a nice introduction for you, Ali, and also for Andrew. What's the solution to Den challenge number 2? That challenge is necrosectomy. That has been so time-consuming, requiring multiple sessions, and very, very frustrating. It's powered endoscopic debridement. So that's abbreviated PED. And it's a motorized, mechanical, non-thermal. It's automated. I mean, we just love everything automated today. We have self-driving cars already. It self-irrigates. The principle is all-in-one device. That resonates with me, with electrocautery enhanced system, all-in-one device. So it sucks, it cuts, and then it removes. Or as the company puts on their website, I think, dissect, resect, and collect. That one sounds nice too, but I like suck, cut, remove better. It has an inner rotating blade that's combined with vacuum. So that's the sucking action. And as this blade rotates, it is irrigating. So it's cooling off this rotating blade. And actually, this device was originally developed in other areas of medicine, notably orthopedics, as a shaver to shave off cartilage. And that was done underwater. So of course I love it. It's all done underwater. That's how I like to do it. And the vacuum level auto adjusts with tissue contact. That's pretty cool. So with that, thank you very much. And I'm so excited about this new space of the extraintestinal frontier that we are now conquering.